Welcome, everybody, to Rise Beyond OCD. This is Shannon Shai. Thank you for joining us. I'm really, really proud of this series where I interview the true icons of the OCD recovery community. And we have a very special guest in that group today. So, first, a few admin remarks. I'm glad you're here. Whether you're living with OCD, supporting someone you love, or working in the mental health field, this is a caring space where we can learn, connect, and find hope together. Just a quick reminder, what we share today is meant for education and support, not a substitute for professional care. And if you ever find yourself in crisis, please reach out. You can call or text 988 for the Suicide and Crisis Lifeline, or 911 if there is immediate danger. For international support, find a helpline.com. Remember, you are not alone. Healing and recovery are achievable, and we are here to move forward together. And before I introduce our special guest today, a couple of other housekeeping items. Today's interview is being live streamed and recorded like all of the other interviews that I've done, and is available. This will be available on my YouTube channel and on my website, ocdrecoveryturningpoints.com. Everyone will be muted, and if you're in the audience, you can have your video on or off. That's up to you, except mine and our guest, of course. Chat room is open. I ask everyone to be respectful of others and maintain decorum. We've never had a problem with that. I do not expect we'll have it today, and we will have a Q&A at the end. Before my final question, if you have a question, please put it into the chat. So now to our special guest. It is my distinct honor to introduce to you Dr. Fred Penzel, a PhD. Dr. Penzel is a licensed psychologist, a former adjunct professor, author, and speaker. He holds both an MA and PhD in school and clinical psychology from Hofstra University. He is the founder and executive director of Western Suffolk Psychological Services. Within his practice, he specializes in the cognitive behavioral treatment of OCD and related disorders. Dr. Penzel is a founding member of both the International Obsessive Compulsive Disorder Foundation, IOCDF, Scientific and Clinical Advisory Board, and the Science Advisory Board of the organization formerly known as the TLC Foundation for Body Focused Repetitive Behaviors, BFRB. In 2011, Dr. Penzel was given the Patricia Perkins IOCDF Outstanding Achievement Award, and in 2019, he was given the TLC Foundation's Christina Pearson Award for outstanding volunteer service. He is also a member of the advisory board of the United Kingdom's Anxiety UK organization. And Dr. Penzel is the author of Obsessive Compulsive Disorders, A Complete Guide to Getting Well and Staying Well, a self-help work covering OCD and other OC spectrum disorders, as well as The Hair Pulling Problem, a complete guide to trichotillomania, a more specialized self-help work. He has served numerous times as an instructor in both the IOCDF Behavioral Therapy Institute and the TLC Professional Training Institute. He has lectured both nationally and internationally on topics relating to OCD and body-focused repetitive behaviors, and has made guest appearances on numerous TV and radio shows. In addition, Dr. Penzel served as an adjunct faculty member and community supervisor for the doctoral psychology program at Long Island University. And on a side note, this was really interesting to me. He has a Master of Fine Arts degree in theater design and technology from the Yale Drama School, and wrote, quote, "Theater Lighting Before Electricity," end quote, the first written history of theater lighting. So, sir, Dr. Penzel, welcome to the program. Thank you so much for being here. You are a hero in my heart. I will say, I tell this to people who, when your name comes up, now and then I'll talk to clients who know you or have heard of you, and I tell them all, I said, Dr. Penzel is quite possibly the kindest, most humble, smart person I've ever met in my life. You are so giving and so caring. And every time I see you, you're gracious with your time with me. But also, as I observe you at the conferences, you're so open to anyone who wants to come talk with you, and you're giving. So I applaud you. I have so much respect for you. Thank you for being here today and sharing with us.
Okay, making me blush, Shannon.
Well, with that bio, we have no time for questions. So
That's it.
we're
Okay,
done.
well, no, okay.
Have a nice Sunday. All right, let's jump into it. What first drew you to working with individuals who struggle with OCD and what kept you committed to this specialty over the years? And as a kind of a follow on question to that, when you think back to early in your career, was there a moment or a patient that confirmed you had chosen the right path in treating OCD?
Okay, that's a question I actually get asked a lot, interestingly enough. It all sort of goes back to a class that I was taking in graduate school in abnormal psych back in 1980. Okay, that's going back a ways. I was told, I'm not only myself, but the class was informed by the professor that OCD was untreatable and not to bother treating it because people didn't improve. And I was sort of brought up to be a skeptic. So I didn't quite believe what he said. And I said, that doesn't sound right to me. I can't believe that there's something that's untreatable because, there's always solutions to things. So I started investigating and I actually found out that there was treatment for OCD. There was over in Europe, there was medication, which we didn't have yet, and there was behavioral therapy, which actually at that time it turned out there were two places in the United States where you could get treatment for OCD. And it turned out that one of them was maybe about 15, 20-minute drive from where I lived. When the time came in my graduate program, we all had to get internships where we were working in clinical settings. So I applied to this place because I thought at the time, which I guess was a little naive, I thought that, gee, if I could treat something as difficult to treat as OCD, then what couldn't I treat? I could treat anything. So I thought I like challenges. So I saw this as kind of a challenge. So I did get an internship there and I started seeing that people actually did improve, that there really was therapy for this. And it was still kind of new, the therapy. We were still developing techniques as we went along at that time, but there were enough techniques and things that we could do it. We didn't have medication, unfortunately, to help us along, but we did okay. I mean, with what we had, actually, I think I don't know if there was one specific moment when I realized that I had picked the right area. I think as sort of went through my first group of patients and saw people recovering, that was very motivating to me because obviously all psychologists, we go into this field because we want to get people better. We want to see them recover. And I was seeing that and I said, gee, this is not only, am I doing something that they say you really can't do, but secondly, it really isn't that difficult to do if you do it the right way. And people get better. And I said, I want to keep doing this. I like this. And I thought the people they were motivated. They were interesting. They were good people, many who had completely normal lives until their OCD entered the picture. And it's funny. When I had my own place, we brought in a psychiatrist who was just learning sort of OCD work. And one of the first things he said to me after his first few weeks, he said, people really get better. Like he almost couldn't believe it. So, that's kind of what's kept me doing it. People really get better. And as a psychologist, I can't ask for better than that. Really, that's the most motivating thing basically about doing what I do.
Well, it's that's interesting that you say that because in my own recovery, when I started to when I started to feel better, let's say I felt like something was changing. That was great motivation to keep going. Right? It was like I'm going to keep doing something that seems to be working. Let me continue to do that, and the more momentum you gain, the easier it does get. I can see the same thing paralleled with actually treating it when you get that positive feedback. Okay, so you've spent decades in this field.
Yeah, this
As
is my 40.
I was just gonna say, yeah, like you got to be getting close to a half a century in this, and which is awesome in and of itself that you have dedicated your entire professional life to this. What changes have you seen in how OCD is understood and treated, and what gives you the most hope today about how we go forward?
Okay. Well, to give some perspective, if you go back to when I first started treating OCD back in 1982, Uh, there were no books. There was no internet, obviously, at that time, really. There were no organizations, like IOCDF. There were no articles you could look up. There were no medications in the US. So it was a wasteland, basically. It was really bleak, and people really had nowhere to turn and really, had nothing in the way of resources at all. So that was the state of things back then. Now, as the 80s progressed, few more of us sort of collected who were able to treat OCD. But at that time, we were still kind of just working in our own separate little bubbles, basically. We really did not communicate. But then the IOCDF came along 1989, New Haven, and it was very interesting because I was running a monthly support groups on Long Island at that time. And I guess they heard about it, and a number of people from IOCDF, the original founders, came down to sit in on my support group meeting because they wanted to see what I was doing,
Oh, wow.
basically. And they were first a little bit skeptical, I think, because they really hadn't run into too many people who were treating OCD. But they'd been in a hospital program, actually, many of them, which is where they met, and mostly were treated with medication. But anyway, they were kind of impressed with what we were doing and what they heard people saying at these meetings, because the meetings were popular, and we would bring in all kinds of, whatever materials I could collect on OCD. We brought in people who had recovered from OCD to talk about their recoveries, and a number of other things. And I talked about treatment and so forth. So it was a real source of information. But then I think the first real big breakthrough came in 1989 when the first medication became available for OCD, which was the drug anafranil,
Mm.
which was a good drug, except it had all kinds of unpleasant side effects. So some people could tolerate them or were willing to tolerate them. Other people couldn't or wouldn't. So there was still kind of a mixing. And then in 1990, Prozac came along, the first SSRI. And that also made a big difference because now we were able to help more people who weren't helped by anafranil. And what the medication did, and what I still say to this day, is that the purpose of medication, it's not a treatment in and of itself. It is the purpose of medication is to help you to do therapy. And that's how it should be regarded. So that enabled us then to reach even more people. And also the IOCDF around 89, it got founded basically and started putting out a newsletter, like a quarterly newsletter. And I actually started writing some articles for the newsletter. I went up to their headquarters and did some lectures up there too. And then they started in the early 90s, must have been around 1990, 91, they started holding national meetings. And there, for the first time, I got to meet a lot of the other people in my field, actually, people who I'd heard names here and there, like in the research and other things, but I'd never met them. This was really a step forward because we were able to exchange ideas and technologies and techniques and things. So that really was a kind of a leap forward because now people knew what other people in other places in the field were doing, and the foundation actually was what brought us all together. Around the same time, around 1990, I also the TLC Foundation for BFRBs also established itself, and I got invited to be on their advisory board. So I got involved in that too. So that was also another step forward because until that time, as little as it was for OCD, there was like even less for people with body focused repetitive behaviors. Also, the drug companies who started coming out with further drugs started putting more money into OCD research, which also gave the field a huge boost. And I think that also they sponsored a lot of lectures and talks at national conferences and things like that. So the drug company money also helped the foundation and a lot of other activities get off the ground. Brain scan studies, which were very expensive, they started doing those, and that started producing interesting information. Then after that, I would say the next step after the growth of IOCDF was the internet, and which of course has turned out to be a mixed blessing, sort of like good and bad information out there. But one really good thing that it did was that it helped people who were sort of far flung all over the U.S. and in other countries realize that they weren't alone, that many, many other people were experiencing what they were experiencing. And it also opened up to them the idea that you could get treatment and that you could, in fact, recover from this. So that was the next big development. And as far as I think what gives me hope at this point, I would say number one, I'm seeing these days more children getting diagnosed and treated at earlier ages, which is very encouraging because most of our patients in the early days started out as adults because children weren't they weren't as well recognized as a group with OCD, although they had just as many kids with OCD and started in childhood for many people. So I think that's helped. And also, I think the number of people who treat OCD has grown tremendously also. And I think that's encouraging. Although I would say all of them using methods that I would recommend. There's greater awareness, there's more treatment, see commercials on TV now. There's websites. There's all sorts of things. So I think just the growth of awareness, I think, is what's going to people are going to demand better treatment, more research. I think, and that's going to also lead to more breakthroughs and developments. I see the other thing that is the work that's being started in genetics also I think is going to have a huge contribution to make, and will also contribute a lot to our understanding, and maybe even new treatments that we haven't even thought of at this point. So who knows? It only gets better. It doesn't get worse.
Well, I mean, I think so. Amen to everything you just said. I also think it's just quite remarkable to me the collegiality that your profession, the people in your profession have. Like, if you ever, if anyone watching this ever, if you haven't been, you need to go. But if you have been, you've seen the same thing to an IOCDF annual conference, and it's amazing to me that we have this group of professionals, therapists, everybody who treats it, researchers, everybody there. But then you have the sufferer community there, and you have loved ones and families there. Everybody is welcome. Everybody finds a home there. But just to watch the professionals, mix it up and talk OCD in the way that you do is just amazing to me. That conference is amazing for many reasons, but that, bringing everybody together, but to watch your profession come together and talk seriously. I mean, everybody has fun while they're there, and it's good to see everybody like a high school reunion. But to watch you actually, practice your craft together is pretty cool. All right. Before we jump into sort of what you might, well, I would consider more of the classic OCD, let's jump into something you do specialize. We've talked a little bit about it. You mentioned it, but body focused repetitive behaviors such as hair pulling, skin picking. Why the specialization, and what can you tell us about those particular disorders?
Well, it's kind of interesting. It's a good question. The way way I got started and got involved in this, well, sort of via the back door, you might say. People with these disorders started showing up where I was working, treating people with OCD. And these people either concluded on their own or had been diagnosed as having OCD, which is understandable because, especially back then, almost anything repetitive was diagnosed as OCD. So they were told, "Oh, you have OCD." So okay, so they went to an OCD clinic to get treatment for OCD. Well, we sort of had to break the news to them that this was not OCD, that it was something else entirely. It was a completely different animal, basically, and that it had a different basis, probably. But there was no place else to go for these folks. The specialists didn't exist back then. There were no clinics, there were no specialists, and there were even fewer resources for that than there were for OCD. So in good conscience, we couldn't turn them away. So we searched high and low for what we could do for them. We knew we couldn't do OCD treatment because they weren't having intrusive, obsessive thoughts, even though they were having repetitive looking behaviors. But actually, at the time, we sort of thought that there were some forms of the disorder that kind of resembled tics, actually, because tics are usually performed to either get a particular sensation or get rid of a particular sensation. And you see that a lot in body focused behaviors. But there were also types that kind of resembled OCD in some ways too. People who were trying to pull out certain hairs or do stuff with their skin to perfect their appearance in some way, or get rid of the hairs that didn't look like they belonged, that didn't feel right, or a different color, or many other reasons like that. So it had a little bit of resemblance to both of those things. So sometimes we use some OCD related techniques for those folks, but for other folks, we were using at the time, it was a treatment that had been developed in the early 1970s called habit reversal training, which was okay as far as when it was very limited in a lot of ways. It only dealt with certain aspects of the problem, but it didn't really get at the whole problem like we're doing now. Basically, we now we do something called comprehensive behavioral therapy, where we try to find all the inputs into the problem and treat all of them and hit it from more of a 360-degree approach, basically. But again, I just want to make it clear that BFRBs are not OCD, and even though it may resemble it in some respects, but again, back then there weren't even many people capable of making a diagnosis. A lot of professionals didn't even know it was what trichotillomania was, and the name was kind of off-putting too, which has now changed. It's now hair pulling disorder and skin picking disorder instead of trichotillomania. And what was it called? The dermatillomania was another name for that. There's been a few names and then there was also nail biting too, which they didn't really even have a proper name for. They didn't know what to call it. So anyway, that's what kind of got me involved in it. And we over the years, it was interesting. TLC did for BFRB treatment what IOCDF did, in that it brought the few people around the country together. And back then, maybe there were maybe probably fewer than a dozen of us in the whole country who were actively treating these things. But we began to talk and share information and techniques and things, and the field kind of gradually evolved to where it is now, which is way better than what we had years ago. And all. So anyway, I hope that answers your question.
Oh no, no, that's a great that's very helpful actually. When people talk about I think it's important to be able to talk about them intelligently, and there are defining factors, and OCD treatment, classic form of OCD treatment may not be the exact thing you want to be doing, although it might be related. So that's very helpful. All right, let's jump into for people living with OCD, what we would consider the more classic OCD. Many people with OCD feel deeply misunderstood. What do you wish sufferers knew about how treatable OCD truly is?
It's kind of interesting because what I have found is that an awful lot of practitioners out there also don't understand OCD and don't get it basically, and they contribute to people feeling misunderstood. The very people you think you could go to for information only
Mm,
add to the problem by either misdiagnosing or giving people misinformation about treatment. But I think what would I like people to know? Okay, let me think about that a second. I want people overall to know that OCD is treatable via therapy and medication, and that there's always hope if you're willing to do the work. I mean, getting recovered is hard work, and I never use the word easy here
yeah.
in my office. You'll never hear me use that word. In fact, there was a saying many years ago by there was a national self-help group called Recovery Incorporated. Now I think it's called Recovery International. But they had like local self-help groups around the country, and they had a lot of sayings to help their members. And I remember I used some of their sayings still because some of them were so clever. One of them said, "The method is simple but not easy." And I agree with that. I think that's true. What it takes to get better, we know what it takes. And exposure and response prevention, in my view, is the gold standard of treatment. And that with medication to assist it, I think we can help the overwhelming majority of people. So I think people need to realize that also, that it's not kind of hopeless or still obscure, even though even professionals may sometimes give them that impression wrongly. I think there are also people out there who look for magic solutions to this, but there aren't any. It's hard work. The only way to overcome a fear is, as far as I understand it, is to face it. And if you ever look at anybody that ever overcame any kind of fear, they had to face that fear at some
Yep.
point or other, basically. But if you understand that, and you understand that getting well is hard work, and you accept that it's hard work and that it's worth it in the end, patients who say they feel like they've been let out of jail basically is the way they describe it essentially. They, in fact, I had one patient who after he recovered, he said, don't be too hard on me, doc. He said I'm only a few months old.
No, that's true. And I will tell you that, well, two things. One is I use that line all the time. The formula for recovery is actually rather simple, not easy, right? I didn't say easy. I said simple. And that's important because OCD will try to complicate this entire mess for you. So keep it simple. And the other thing I would say is, and I tell people this, if you see somebody trying to tell you that they have the magical cure for OCD and all you got to do is their 1 day program, that's not how this works. It is not. It's a journey and it's difficult, but it isn't complicated. So we can keep it that way. The other thing I don't like is when uh, and I, when you talk about treatable, I tell people there are the three most important things I can tell you, and I'm going to only talk about the first one here. The three most important things: the disorder that you suffer from is treatable, right? It's treatable. I had somebody tell me, Dr. Penzel, one time, I would trade this for any other illness. I go, why would you ever say that? Right? You have an illness that's treatable. And so anybody who only talks about it cannot be cured. You're going to live in misery. That's your goal. Learn how to live in misery. I say, don't listen to it. Do not listen to it. And that's why I have people like you here. All right. How can someone distinguish between normal doubt, right? Because we all have doubt, normal doubt, and the kind of doubt that fuels OCD?
Well, I think it's funny. Back in the 19th century, it was called the doubting disease, and they didn't know exactly what it was, but they could see that one of the chief features of the disorder was doubt,
Mhm.
basically. OCD related doubt, I think what distinguishes it is that it can never be satisfied no matter how much information you have. And I tell people, I say, you could have a library full of information and it still wouldn't help because it can't be satisfied through logic or information. It's not possible. It's like OCD doesn't allow people to process that information. People, obviously a lot of compulsions are about getting information in order to get certainty and to get rid of anxiety and even the thought. But as it turns out, it's only good for, a few minutes or a few hours, short term, and then it comes right back again. Now, normal doubt, you can, engage in logic, you can get information, you can have things explained to you, and they say, okay, I get it now, I understand, so I'm not in doubt anymore. But with OCD, that never works. That's what's so maddening about it, and what's so incomprehensible to people who live with people who have OCD. They'll say, well, why can't you understand this, or why can't you see that that's not true, or why can't you see that there's an answer to your question? But there just isn't. There's no answer to obsessive questions. There just isn't. And we don't even try to answer them. And in fact, attempts to do that are compulsions, basically. Reassurance seeking is one of the main ways that people do that. So it can't possibly help. So I think that's really what distinguishes the two. Regular doubt, can be satisfied. Obsessive doubt cannot be satisfied. That if you want to really boil it down to the
So
basics.
that's a great answer. And so you mentioned how difficult recovery can be. It's simple, not easy, right? So for those who feel stuck despite trying therapy, what are common barriers to progress that you see and how can they be overcome? So let's
Oh
talk
boy,
about
yeah.
that journey of recovery and how difficult it is.
There's loads of them, quite a few, and I've seen just about all of them over the years. First of all, some people don't think that they have the ability to recover. Their fears are too intimidating to them. They're so powerful that the person says, "No, my fear is so strong that I can't even take a chance on it coming through." So there's things that they just won't do, the very things they need to get better. Some people are when they hear what the therapy is all about, they're afraid that therapy. They say, "Well, won't that make me worse?" So they say, "I don't want to mess with it." Like they think they can establish some kind of a truce with OCD. Like if I don't bother it, maybe it won't bother me too much. But of course, that doesn't turn out to be true. And it doesn't. And therapy doesn't worsen symptoms. The purpose of the therapy, yes, is to help the person to confront and build up their tolerance to greater and greater amounts of what they fear. But we don't. It's not like throwing people into it head first. I tell people, I said it's not like teaching someone to swim by throwing them into the deep end of the pool. What we do here is we do it. It's gradual. It's step by step, and that's how it's done. And it's done in a humane way, and it's done with the person in mind. With the consideration for what they can tolerate and all. As I'll probably mention during a number of my different answers here, there is no one size fits all when it comes to treatment. Treatment has to be tailored to each person, the way they work, to their needs, to their symptoms, to their lives, in many different things. Like some people I've met think that it's unfair that they have OCD and that it should just be taken away from them somehow, and that it's unfair that they should have to work hard to get out of it. So that's another block to do. Some people have a low tolerance for frustration, because you don't get better overnight. Sometimes you take a step forward and sometimes you take a step back. But if you keep working, you keep moving forward, but they want to see instant results, and their impatience gets the better of them, and they say, well, I don't want to, I don't want to keep doing this. It's going to take too long, or I don't see an end to this, and so their frustration overcomes them. Another block is severe depression. Some people are so depressed that they just can't get up the motivation to actually follow the treatment. They're just too everything is just too negative. They're too fatigued, they're too hopeless. And so I always tell people never underestimate the power of depression. So sometimes that needs to be treated, but unless they're getting treated for that as well, that can be a block to treatment. Now, there's depression that's caused by having OCD, which gets better as the person gets better. But then there's like major depression, which is a separate disorder, which even if a person recovers from OCD, they're still depressed. So that can also get in their way. Also, stress in general. People have stressful lives or stressful life situations. That can be a block to treatment because stress is along with having too much time on your hands is what can worsen OCD for people. So that makes it a tougher job for them. Also, some people suffer from morbid obsessions, and they believe in an OCD kind of way that their fear is the only thing that's keeping them from acting on their violent thoughts, basically. So I don't want to get rid of the thoughts because that's all that's holding me back. And if you take that away, that's going to release me, and I'm going to do all the things that I'm afraid that my thoughts are going to tell me I'm going to do. Another one is some people just don't see their symptoms as a problem. Interestingly enough, they say, well, it helps me to do certain things, or it makes me more perfectionistic about getting things done, or it protects me in certain ways. And that's obviously pretty distorted thinking, but some people come in with that. Some people also are in denial about the seriousness of the disorder. They say, well, I can still go to work.
This is a really important topic, and
Yeah.
as you keep going, let me just I want to throw this sort of very related question as you continue talking about this topic
Yeah.
because ERP can feel so frightening, right? And how do you help patients move forward when their fear is so overwhelming, right? So, if you would integrate the answer to that question with this larger integration about barriers and
Well,
about recovery.
yeah, before I get on with any of the other barriers, I will say that all good treatment starts with not only a proper diagnosis, but the next thing that follows after that is what I would call psychoeducation, which means you really need to educate people into what they are dealing with, what OCD is, what the nature of it is, what the nature of treatment is, what it's supposed to do, how it's supposed to work, what they can expect and all. And sometimes that can move a person to do that. Sometimes I'll network somebody with somebody who's recovered, who's willing to discuss uh, their 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 recovery with this person. To actually, a person can hear it from somebody directly. I said, if you don't believe me, talk to somebody who's been through the process and see what they have to tell you and all. So that can be a big help also. And also, again, as part of the psychoeducation, we make it very clear we're not going to hit you with more than you can tolerate. We're going to do it very gradually, step by step. And in fact, I always tell them the old joke. I say, well, how do you eat an elephant? And the answer is one bite at a time. So I say that's how we're going to do this. Basically, we're going to do it one bite at a time, and we're going to, and we'll tailor it to you. We're going to be partners in this. It's not like you're going to passively sit there and we're going to inflict things on you. So we try to make it very clear that this is a cooperative effort here and that we're going to work together. And I tell them, I say, look, if you feel you're not ready to do something, say we'll carve it up into smaller steps. We'll make it more doable. If you can't do it in a whole step, we'll do it in a half step, or we'll stretch it out, or there's many different modifications we can make because we want you to be overall, we want you to be a success and we want you to feel successful. So
I wish that answer right there, and whenever I publish this, I'm gonna point people to that answer right there. I wish everybody knew that because I talk to people, I hear people, I read it on the internet, which is again some of the downside of the internet, that people are so afraid of ERP because they just feel like they're going to be asked to jump off a 1,000-foot cliff. And I'm like, it doesn't work that way, and it doesn't have to work that way. Uh, and certainly I have no place in teaching therapists, but people like you do, that if there are therapists who are actually doing that and scaring people out of recovery, that is the point that needs to be made. So anyway, I will refer when I publish this back to
yeah,
this segment. Go ahead.
some therapists are so zealous in not getting people better that they do push them too far and too fast, and it scares them out of therapy. And I sometimes these people then come to see me, and they say, "Are you going to do that to me?" And I say, "Absolutely not." I said, "That's a kind of a rookie mistake. Basically, we don't do things like that." I said, "If I treated people like that, I'd be sitting in an empty office all week. I'd scare all my patients away. It wouldn't suit my purposes and it wouldn't suit your purposes. So why would I want to do that? The whole purpose is to get you better. And everything is dedicated to that main purpose. And if it doesn't fit that, we don't have time for it, basically. I could go on. There's many other reasons why people don't get better or why they struggle with the therapy. But there is one other one I would like to make a point of because this is very, very important. And people don't quite get this all the time, but it's something over the years I've come to realize is that OCD itself, because it picks on things that are important to you, it will pick on a person's treatment. It will tell the person flat out, you can't get better. You're in the wrong treatment. Nothing can help you. You don't know how to do therapy. You're not doing therapy right. It can make people try to do the therapy so perfectly that they turn the therapy into compulsions, and then that works against them. So OCD itself, I tell people, I say, expect that OCD will attack your therapy. In fact, I don't know if you've seen it. I have this document out there online. It's called 25 Tips for Succeeding in Your OCD Therapy.
Okay.
I made it up originally as a document to give to my new patients, but the OC Foundation put it on their website actually, and a lot of other therapists are now using this, handing it out to their patients because I tell people it's the ground rules basically. It's your manual essentially. If you have any questions, always refer back to my 25 tips. It's on my website too, by the way. Anybody can download it, and,
Yeah. I'll make sure all of that is available that people can find your stuff.
people really like it. In fact, I have patients who will refer to things on it by the numbers. Say, "Oh, that's number 17" or something. I tell people, say, if you can memorize it, it's so much the better. I say, photograph it with your phone and have it with you. So, but I want people to know that that some of the problems that you're having with therapy can be actually related to your OCD as symptoms. So
That
don't mistake that because people don't realize that, and a lot of therapists don't realize that.
okay, so, I'll make sure all of that is published out there for people. Let's continue on this theme, I guess, but go to one I hear about all the time, and it was actually something that I suffered with a lot. What would you say to someone who worries that not performing the compulsion means that they're being irresponsible or careless, right? That this is a very prominent fear that people are like,
Yes.
it feels so irresponsible for me to do what this doctor is, or even if Shannon is working with him, it's so irresponsible for me not to take this seriously. Go ahead.
Well, I think it's really vital for people to understand that having OCD is not their fault. Okay, they didn't ask for it. It's not voluntary. It's not something that only happens to not nice people or anything else like that. And that the one of the important things to understand, and I tell them this, I said OCD gets to pick the topic and you don't. Okay, so you have no say in the matter, and I say the proof of that is that you can have one particular obsession for a while, and then like overnight, it'll just shift to a completely different topic. I have people whose topics have changed like from day to day or week to week. Interesting thing is the person will then say, "Oh, that previous topic, I don't care about that anymore, but this new one, this is really important." They can be on the variations on a theme, is what I like to
Yeah.
call them, but in any case, they're not responsible for the topic. They're not responsible for the fact that they have OCD. And this is all part of what I was saying before. Is a good psychoeducation is teaching people. It's not just leaping into treatment, but teaching people what they are treating and what and why we do what we do, basically. So, and again, I tell them the OCD has this uncanny ability to pick on things that are going to bother you the most. Why it does that, nobody knows. We still don't understand that, and we don't know why particular people get particular topics. But I've usually been able to explain this to people's satisfaction enough that they're willing to take it on and do it, even though the thoughts tell them that, they're evil and blasphemous and dangerous and nasty and all kinds of things. But you have to do that right at the very beginning and all. So, we tell them, that guilt and doubt and shame are often a big part of these things. And again, I think also once they get out there and see that, and I show them how, so many other people have the exact same symptoms
Yeah.
that we have, that kind of helps also. It kind of normalizes, if you will, the thought itself, saying, well, thousands and thousands of people have the same exact thought as you do, and actually you can look online and you can see that they do, basically, and that these people even given names to these different themes at all. So usually we can get people motivated to face these things, that to not feel that it's their fault in any way or that they're going to be doing anything. In fact, when it comes to religious stuff, we often recruit religious figures from within their own communities to help them and encourage them to see that their thoughts are not their fault, and it's not it has nothing to do with their beliefs or anything else. In fact, when they're religious, I tell people, I say our goal in doing the therapy is to get you back to normal observance like everybody else also. So it's not to make you irreligious or anything else like that. We don't want that. We want to have you. Our goal is to be like the average person, basically. And I said, if you want to be like the average person, you have to do what average people do. Can't keep doing what you're doing. And the people, and I've had religious leaders tell people, they say, look, and this is not normal. This is not, and what you're being asked to do is okay, and it's not blasphemous or bad or anything else like that. And there's one thing I often tell people too. I say, do you believe that God knows and sees everything? And of course they'll say, well, yeah, of course, absolutely, no denying it. And I say, well, if that's the case, then wouldn't God know that you have OCD and that you're just trying to get better? And that really kind of brings some people up short. So they, wow, I never thought of that before. But it can sort of help them to find some motivation because they say, yeah, how could God not know that?
I think that's that really good point because there's a big debate out there and has been ever since I did what I did. And I tried to find some marker of normalcy to shoot for because I had lost the ability to function like the average person, and just I had no idea what the right answer of anything was. So I just tried to say, what would a person who doesn't have OCD, how would they act? Wasn't no science behind it, no research, but it was sort of a marker. And it wasn't reassurance because that was the debate. People saying, you're just reassuring yourself. I said, no, I have to have some clue as to what it feels like to live normally again. And
No, the
so
new
it's
standard.
helpful to know that these things aren't actually bad, that OCD isn't me, I'm not OCD, etc. That's a really important point. And in the interest of time, we're going to move on, but I could probably talk to you for about 10 hours. I'm not going to
Sure.
do that to you on a Sunday, but let's shift to family members briefly. What are the most common ways loved ones unintentionally accommodate OCD, and why can this make recovery harder or more difficult?
I think family members do this in several ways. They assist in doing rituals, they answer obsessive questions, they reassure, as we were just talking about, and they excuse individuals who aren't well from taking their place in doing everyday life activities. They function for them so that they don't have to. Basically, so it's what is known as enabling. And you see this in like substance abuse also. It's a common thing, and it's understandable. People don't want to see their loved ones feel anxious. They don't want them to be in pain. They don't want them to be unhappy, and so they think they're relieving this. They want to help solve the problem, but of course they make the same mistake that the person with OCD makes, which is they try to show them how to stay away from or avoid or escape from whatever it is that's bothering them. So what they don't understand, and what I try to teach everybody, is that OCD is paradoxical. In other words, all the things that you think are going to make you better make you worse, and all the things that you think are going to make you worse make you better. Along with educating the person themselves, we have to educate the family members. And we tell them, if you do this, if you try to take away what's bothering them, you're depriving them of the opportunity to learn to help themselves. And
Yeah.
so like I said, we educate them. I give family members homework to do also, which mostly involves standing back and letting the person face the problem themselves and indicate how what they've been doing only makes the person worse. They say, you don't want to make your loved one worse, do you? And this is how it's going to happen, and they get it, generally speaking. And sometimes the patient doesn't like the fact that the other person will no longer do these things for them. But I tell them, I say, look, don't get angry at your family member. I said, if you don't like it, get angry at me because they're just following my instructions. So if you don't like it, come to me and you can let me have it. I said, but I can take it because I'm not emotionally involved with you like your family member is. I can stand back and explain to you why we have to do what we have to do.
Yeah, and that's a good segue to this next question about how can family members set compassionate boundaries without feeling like they're abandoning the person that they love, right? And feel like they're actually helping when on its face all you see is pain and probably the person who has OCD yelling at their family member, right? Because they're not doing it. I think I'm gearing you up for another 25. So go ahead. What do you tell family members?
Well, generally, I think, first of all, it's a good idea to get professional help with this so that the sufferer can accept that their loved one's enabling behaviors are hurting them rather than helping them. It needs to be explained to them. They need to hear it from a neutral third party, basically, and when we explain to them how it's hurting them, how it's depriving them of again, of needed opportunities to improve. So, again, we talk about the paradox of OCD, and we try to be humane about it, and we tell them that we're going to gradually withdraw that family member from these behaviors because it's toxic for them, and it's only going to hold them back, and will put off their recovery. And so, we don't advise family members to just drop everything cold turkey because that's just not realistic. We don't do therapy like that either. So
Right.
we have them withdraw gradually, and we explain that we will. And the person, we don't bring anything on them by surprise. The person with OCD knows everything that's going to happen and how it's going to happen and what they can expect. We want to avoid fights and resentment, and all. And believe me, that can certainly happen when people try to do this on their own. I've seen it, but we try to make the process as stress-free as possible. I know we can't make it totally stress-free, but we try to make it as easy as possible, and make sure that everybody knows their part in this, that they know what their role is going to be. And again, if a trained therapist advises everybody to do these things, there's more authority behind it. Basically, it's not just like, they can say, oh, to the family member, oh, you're being mean, or you're just nasty, or you're angry at me because I have OCD and you're just trying to punish me. But we explain that no, and in fact, I tell family members to answer things like that, to say, no, if I was trying to punish you, I'd leave you the way you were.
That's a great line. And also, hey, Dr. Penzel told me to do this.
Exactly. That's what I tell them to say. Say, I'm only doing this because Dr. Penzel told me. So if you don't like it, take it up with him. And I think we talked about it in your session. We agreed to this. So let's all try to do our part here. I'm trying to help you. You need to help yourself.
All right, what advice would you give parents who are unsure whether their child's behaviors are OCD or typical developmental phases? And I suppose with child, we could probably go all the way up through teenage years. What do you instruct people about that?
Well, I think, first of all, as I said, with family members, there's no real substitute for a proper evaluation by a trained professional. So I think that's really important. Primary care physicians or pediatricians are probably not the best people to do these things, because their knowledge is very limited, and they're not really, unless they've had specialized training, they don't tend to be very knowledgeable about these things. Like, oh, they're just going through a phase, or it's something else, or it gets kind of muddled, and they don't know what they're talking about. Basically, nice people, and they're good for certain things, but OCD is a whole subspecialty. So, but if we're talking about, again, find a specialist is my advice. But tip-offs, as far as parents go, things that they can spot to begin to get an idea that something's not right. Some of the things would be like just very unusual fears, kids being afraid of certain things, although some fears are typical too of young kids. But again, they can't be explained away, or they can't be reassured away. Declining schoolwork is always a symptom of a lot of things. Actually, by itself, it doesn't say that, but declining schoolwork. Serious perfectionism, like kids who stay up all night doing homework, or erase holes in their paper trying to make the letters perfect, or things of that nature. This is stuff we see. Repetitive questioning that just won't quit. Like we said earlier about the doubt that you just can't just wish it away. You know, it's always about similar topics. Serious saving of useless and worn out things can be a topic. Excessive washing and cleaning, which of course is sort of a cliche in the OCD world. Kids who won't let people in their room or touch any of their things or move anything, or if something's moved, it has to be put back in the same exact place again. Kids who try to keep everything pristine and won't use a lot of their belongings. These are all typical things. I could go on and on. I mean, the list is really enormous, but these are just a few. Now, there are some other problems, of course, that resemble OCD, such as ADD, autism spectrum disorders, and tic disorders. So sometimes those can look like OCD, and this is why you need sometimes a professional to help, kind of separate these
Yeah.
things, and see what's really going on. So again, you may have your suspicions, but you want a professional to confirm what's really happening. So that's my advice.
No, that's really helpful. Uh, let's talk about couples. How can couples navigate OCD when reassurance seeking or avoidance starts affecting the relationship?
Okay. Well, again, my main advice is get that person with OCD into treatment. If they're having a little trouble with that, I would say get information. You can get them to visit the IOCDF website, or other reputable websites that have accurate information about the nature of OCD and what it is. There's some good articles out there, and well, I've put about several dozen articles about different forms of OCD on my own website that people can download and read and do whatever they want with, that I've written over many years now. But it's important for the non OCD partner to realize that their partner isn't doing this to make their lives difficult, and they need somebody to intervene. They need like I said, a neutral third party, basically, who can establish ground rules, uh, and to indicate that your partner is not responsible for the fact that they have OCD, but they are responsible for doing something about it, for getting better. That is their responsibility. But I usually caution people against trying to act as therapists for their loved ones, It's not a good idea in general. First of all, you don't have the objectivity; they're too emotionally involved, so that's one big roadblock there. And treatment, I think, can sort all this out and can really show everybody what their role is and what they need to do. And it may vary, in relationship to relationship. I think again a proper sometimes even it's gotten so bad that I've even had to refer people for couples therapy in addition because
Mhm.
I don't consider myself a couples therapist. I don't, it's not my expertise, but I have people that I refer to try to get people to hash out other issues that have cropped up, other non-OCD issues that may have even pre-existed the OCD or just made worse by it. But the main thing is, again, everybody needs to know their role in this and what's expected of them and how to best carry it out.
Yeah, and this might be an unfair question because I didn't write it down for you and told you I was going to ask it, but it's
It's okay.
important, and you're a smart guy. Those are delicate conversations to have, and even if I mean, it doesn't have to be just couples like boyfriend girlfriend. It could be parent teenager. When you're trying to suggest to somebody that maybe they do need to go see a professional, a therapist who might be able to help, that's a very delicate conversation because the person receiving that information can be defensive, resentful, protective, a lot of different things. What are if you've thought about this, you probably have written about it, but what are some ways to compassionately coax somebody into therapy under those
Yeah.
circumstances?
Well, I think probably first and foremost is to realize that maybe you're not going to succeed all at once in the beginning. I think a place to start is to just acknowledge by saying, "Look, I see you're really suffering. I can. It's pretty clear you're suffering,
Yeah.
and it looks like it's becoming increasingly so. That it's just getting worse over time. And do you want to talk about it?" Just to start. I mean, not make it very threatening or confrontational or
Right.
anything like that, but give the person out. Maybe they may say at the beginning, "No, I really don't want to talk about it," and all. And sometimes you just have to let it sit and let it percolate a bit. And sometimes I've had people get information on OCD, just leave it around, don't even tell the person that it's meant for them particularly, but just leave it on the kitchen table or someplace, where they're going to see it, and then hopefully they might get curious enough to want to look it over, and the person may come back and say, "Yeah, I read that article. It sounds like me." Or another thing you can do is say, "Look, I read an article about OCD, and it sounds like you." Basically, why don't you read it and see what you think, if you think it sounds like you, or if you care to. That's all. But we don't we take a more light handed approach. Basically, we don't try to push the person or bully them or force them into anything or intimidate them or like some people say, "Well, if you don't get better, I'm leaving," and stuff like that. I mean, it's like just piling stress on the person. It's only going to make them worse.
No, that's a great answer. Let's shift gears now and talk about therapists. And certainly you've trained a zillion therapists. So there's a few of you that I consider to be at the top of this heap of training people. What foundational principles should every new therapist understand before beginning ERP with clients?
Okay, there's several things actually, and when I do supervision groups with other psychologists and all, I tell them there's a few things that you need to know right at the beginning before we even get into anything else or we talk about your cases. Okay, so these things are: one, I say you can't help everyone. Some people are not ready or willing to recover when we want them to, and we can't make them. So that's one thing. Like some therapists get burnt out and blame themselves, or they get angry at the person, whatever. But that's all misplaced. We just say it's not. It may just not be the right time. That's all. We have to accept that. I've had people go away and come back months or even years later, sometimes when they were ready to do it, and then they were very successful. But not until that happens are you going to see anything. Another thing is that the overall goal is to teach people to take responsibility for their own disorder and to learn that they they need to become their own therapists and to become self-sufficient with their disorder. That's one of the main things we want to teach. Also, as mentioned earlier, that therapy must be tailored to each person. That there's no one size fits all, as I said, and also. We take a more gradual and humane approach. I like to say we use a scalpel instead of a sledgehammer, basically. So we don't want to let our zeal to make people better get in the way and make us overwhelm the person. Treatment should be comprehensive, and we should try to get at the disorder both behaviorally and philosophically, and to try to get at it from every direction possible. I think that wellness comes from a state of balance, and that means I look at the person's their sleep habits, their diet, the state of their health, whether they've got any kind of productive work or not, their relationships. We look at all these things in addition to the OCD, because if these other things are out of balance, they're going to affect the person's ability to recover. So we want to balance everything out essentially. So, which is why therapy, as I said, has to be comprehensive. And getting back basically to the OCD itself, like I said, it's not just changing a person's behavior. We have to change the way the person thinks. Because if we change the behavior and they go away still thinking about OCD in the same old ways, we're going to find them coming back again in a lapsed situation where they've gone back to doing something, because their basic view of things like uh, what am I thinking of here? Things like uncertainty and risk. Their thoughts on uncertainty and risk have not changed, and we have to change that. Well, I tell everybody they have a philosophy, whether they know it or not. They have a set of beliefs and a view of the world and themselves, and we have to see, where that's helpful and where it isn't helpful. I tell them a good philosophy gets you over the rough spots in life. Of course, philosophy just throws more fuel on the fire, basically. So again, we want to hit that problem from every direction. And in general, as I said, we go gradually. We go at the person's pace. We don't push them too hard, and we gradually shift over responsibility for the treatment to them. Toward the end of therapy, I have people creating their own assignments and assigning themselves homework rather than having me do it and then reporting back to me. So I tell them, I say, you're a therapist in training for yourself.
Yeah. So, what mistakes do you see clinicians commonly make when treating OCD for the first time?
Okay, several things. First of all, the most important thing, and one of the biggest mistakes, is to not get proper case supervision from somebody with real experience who knows what they're doing. Because otherwise, I mean, if you don't know anything about what you're doing, or you only know a little bit, you're not going to be able to answer your own questions. You're going to really be floundering around here when you talk to somebody who's done this like hundreds of times. They're going to be able to cut right through that and help you to be more efficient. So another one is not doing a proper initial evaluation, like getting at all the symptoms and all, and really pulling things out of people. I mean, what we don't want is, I tell them, I say, 6 months down the road, we don't want to have the person say, oh, by the way, did I tell you about my alcohol problem? So you want to do a real good evaluation. Next, we want them. The mistake is not doing proper psychoeducation, as I've already mentioned, really, educating people about OCD and therapy. Another one is pushing people too far, too fast, which I think I've sort of explained why that's a bad idea. And not being comprehensive enough in their approach. Sometimes I've seen people who've been in therapies, they only got like one homework assignment in a week to work on one thing, when, they had like myriad things going on that they could have and should have been working on, but weren't, and probably would have taken years at that rate to recover, if at all. Also, I think another mistake they make is not recognizing the presence of tics, or what we now call Tourettic OCD, which is people performing tics as compulsions at all, which nobody ever used to know anything about or even recognize. In fact, my good friend Dr. Charlie Mansueto, who I think you've done one of these sessions with, was the one who came up with that term. Actually, he's a very smart fellow, and but that's another thing. They need to know that these things exist, basically, and also that autism, not screening people for autism spectrum disorders, is a big thing. Some some of the behaviors seen in autistic people resemble OCD, but only because they're repetitive, not because they come from OCD. I have an autistic son myself, so I know I'm lucky enough to have a feel for autism myself, and treated many people on the spectrum. So it's important that they know that these folks are out there, and we'll come to them for treatment and need to be treated sometimes in ways that are not exactly like you would treat somebody who's non-autistic. And then also, I think finally, not appreciating or considering the role that physical ailments can play, or side effects can play in symptoms that they're observing. Like, I have people who can't get out of bed in the morning, and it turns out it's not because they're depressed, it's because their medication is causing fatigue, or they have high anxiety due to episodes of low blood sugar, or patients who have like heart palpitations because they actually have a cardiac problem. There's all kinds of things that go on that we need to be able to screen people for, and puts a lot of responsibility on us. But it's all about knowing your business. It's like a good auto mechanic has to be able to turn on a car's engine and listen to it and drive it around a little bit and see, what needs to be fixed. It's no different with this in a sense.
Yeah, no, that absolutely, amen. That's a great answer. All right, let me turn to our audience. Here's the question, and this is a really good question, which I think a lot of people are feeling. A big challenge with OCD is when there is a real event that takes place, and OCD takes advantage of this event to make you feel bad about yourself and scare you with the consequences that could happen or will happen. The question said will, but I'll put in could possibly happen. Any suggestions on coping with real event type situations?
To be honest, I never quite understood why people sort of separate that out as a different kind of animal in a way. It's still doubt about something. And what we expose people to is not the situation itself. We expose them to the doubt about the situation. And what I have people do is actually agree with the thoughts to say, yeah, it's true, or yes, it happened, or yes, it's going to happen, or the worst that I think about it is going to happen. But we you can do exposure to anything. People think that some types of OCD are harder to treat than others, but they're not. All OCD is treated according to the same principles, which we adapt according maybe to the topic, but it's not treated as any different thing. Basically, like a person says, "Oh, I'm afraid, 6 years ago I ran somebody over at an intersection." Or something. So we instead of trying to examine, the implications of that, we just say, yeah, you did, and they're dead. It's your fault. Doing that over and over and the goal is to build up a person's ability to tolerate the thoughts, because you can't not think a thought. You can't push a thought out of your head. It's an internal event, so there's nothing you can do about it. So you can either you can't ignore it basically, because it really broadcasts itself. So what you can do is you can build up your ability to tolerate it. In fact, I just had a patient of mine recently say to me, he had recovered, and he said about his thoughts. He said, "You know what?" He said, "Yeah." I said, "I still get the thoughts." He said, "But I don't care about them anymore. They're not important." He said, "I get them, but I just let them happen and I go about my business. That's all." He said, "They have no real interest for me anymore." And that's we're trying to get to that point. It's like one of my psychologist buddies said, it's like, like watching a horror movie 1,000 times, essentially. And that's what we're trying to do. We can't make the thoughts go away. We can get people to stop doing compulsions, and we can stop avoidance and escape from these things. And that will enable them to live a normal life, because it's not the anxiety that's the problem. The compulsions are the problem. And they're what drive the whole thing. Once you get rid of the compulsions, that's when you see a person recover.
Yeah, I mean, I thought that's a great answer, and I tell people that ultimately, regardless of the technique that you use, like if you could say, "Yep, okay, that's true. I agree with it," or you could go to the other side, and this is what I did, was like, "I think that's coming from OCD. I'm not giving value to it." Either way, you're being told, "Don't do anything about it." To be indifferent to the presence of the thought, let the thought be there. But indifference is, in my view, this is just Shannon Shy's view. Indifference, as I look at all of the different techniques there to help yourself not perform the compulsion, indifference seems to be the common thread that weaves them all together and saying, I can let this be here. I don't have to do anything about it, even if it's true, right? You could go to that side, or you could say, "But because it has no value, I can be indifferent about it." I could be wrong, but what I do know is I know a lot of people who've gotten well on any of those different techniques, and indifference is always sort of the key.
Whatever we do, we have to allow the thought to be there, because
Right,
you can't run away. I tell people you can't run away from what's inside your own head. You take your head with you wherever you go. So there's
right.
no escape from it. So you have to learn to tolerate it, because what else can you do? I mean, it's either that or let yourself be overcome by it. But I don't recommend that.
That was the epiphany of my own recovery, doctor. That was when I figured that part out, that allowing the thought took most of the leverage away from OCD. When I said, "I don't care if it's here."
You're
Um,
agreeing to tolerate it.
yeah, yeah, and so, all right, I don't see any other questions. That's a great
Yeah.
answer. It was a great question from Sam. I have one final question for you, and then I'm gonna let you go and enjoy your Sunday. I'm very tempted to ask this Master of Fine Arts question, but, let me jump to, the other one. I'll talk to you about that at the conference. Like, what was your interest about there? And you can talk about it if you want here. The question I have for you with regard to OCD recovery is, what lasting words of hope and encouragement can you give to those who are suffering?
Okay. Really, when you really come down to it, I'm a very simple person. I like to keep things simple myself, and I think the answer to that is pretty straightforward and simple too. Number one is that OCD is something you can recover from. I mean, I've treated probably well over a couple of thousand people in the last 44 years. So I would say that I know that you can recover from it. I believe that everyone has it in them to recover if they can find that within themselves, and that they just have to get to that enough is enough point, I think, or I'm not going to put up with this anymore, or I refuse to live this way, whatever spurs that person on to do it. But I think once a person reaches that point, they can recover, certainly. And I think that there is help out there now, more than there ever was before, certainly more than when I started. So the help can be found. And even self-help, there's a lot of self-help material out there which didn't used to exist. And also I think the other important point is that for people to realize they are not alone, that millions of people out there have this. And I know this because I get emails from all over the world because of my stuff I post online and everything. And I mean, when I get in touch with people like on a small island in the Indian Ocean, or in the middle of Africa, or the west coast of Australia, or northern Canada, and they all sound exactly alike. Everybody's OCD is the same. The topics are the same. The way they describe it is the same. And in fact, I'll tell you something else. There's a phrase that everybody uses that is almost universal, that every patient that I've ever treated they've all said this at one time or another. And I'll tell you what it is. Very, very straightforward. They say, it seems so real. They all say that almost the exact same words. It's uncanny. And I hear this, but again, OCD is in every continent, it's in every culture, it's in every race, it's in every country, it's everywhere. It's permeated the world basically. But you're not alone, and there is help, and there is hope. For as long as a person is willing to work on it, there is hope. If they just sit back and want it to be taken away from them, then that's not going to happen. But if they're willing to do the heavy lifting and do the hard work, they can recover from this.
You are a prince. I mean, very powerful words. I want everybody to watch this, and I can't thank you enough. I mean, I really am honored and humbled that you agreed to do this, but you certainly are at the top of the pyramid with it. There's a lot of people who treat OCD, but there's a few of the icons that are at the top of the pyramid, right? And you are so impactful to this. You have been impactful. You've brought OCD treatment and recovery to where it is today, from the dark ages to now. Not that you are that old to dark ages, but you brought
I
it.
am old, actually.
And you've set the stage for the future. And I know that there's many therapists running around who are students of yours as you've gone through. So I just, on behalf of everyone who's ever suffered, I just want to thank you from the bottom of my heart for everything you do, as selfless and giving as you are. I just want to say thank you. So with that, we can bid everybody farewell. Have a great rest of your weekend, and I will see you in Seattle, I'm sure.
Thank you, and thank you for the privilege of allowing me to express myself here, and to all the people with OCD for allowing me the privilege to help them and dedicate my career to helping them.
Of course. All right. Goodbye, sir. And everybody have a very happy Easter and a great rest of your weekend. This will be put on my YouTube channel at some point in the near future. All right. Bye bye. Bye, everybody.